So Olu Ajilore is our next keynote. He's a professor of psychiatry within the University of Illinois Chicago Center for Depression and Resilience. He holds multiple leadership positions at the University of Illinois Chicago, reflecting his innovative approach and impact on our field. He's director of the Mood and Anxiety Disorders Program, director of the Clinical Research Core within the Center for Clinical and Translational Science, and director of the Adult Neuroscience Residency Research Track. And Professor Ajilore is an alumnus of Stanford, and I learned today, went to medical school with Carl Diceroth, so our small world is getting smaller. It's been an absolute personal privilege and also a lot of fun to collaborate with Professor Ajilore on a major collaborative project spanning our two institutions. And perhaps you'll hear a little bit about that today. So join me in welcoming Professor Ajilore to the podium.
Thank you, Leanne, for that kind introduction. And I also want to thank Leanne and the team for inviting me to be a part of this incredible symposium and the chance to come back to Stanford and see new familiar faces and old familiar faces. It's been a real pleasure. And I also want to applaud the wisdom of the scheduling committee, because they placed me after a lot of incredible, wonderful talks that have actually set up really well what I'm going to talk to you about today. Let me make sure this works. All right, so the title of my talk is Neural and Digital Signatures of Affective Disorders. I will also talk a little bit about our work with anxiety disorders as well. Here are my disclosures. The work that I'm going to be talking about at the end of the talk has been licensed to a company that I co-founded called Keywise AI, but most of the work that I'm going to be talking about has been funded by the NIMH and the Robert Wood Johnson Foundation. So by way of overview, I'm just going to start with a brief introduction into network neuroscience and how we use graph theory to basically understand the brain as a network. And then I'll talk about how we can use these methods to identify targets that inform how existing treatments might work and how it might help us identify novel target development. And then I'll talk a little bit about our work with digital biomarkers, and then at the end talk about how we're trying to synthesize our neuroimaging work with our digital biomarker work. So I always like to start off my talks about network neuroscience with a picture of this gentleman, Sir John Batty-Tuke, who was the president of the Royal College of Physicians in Edinburgh back at the turn of the last century. And he was quite a remarkable psychiatrist. He was a very strong believer in the humane treatment of patients and was a strong proponent of biological theories of mental illness at a time when people still thought of them as moral infirmities. And he had this incredible series of lectures where he talked about some of these biological theories called The Insanity of Overexertion of the Brain. And you can actually Google this book and read about it. There are a lot of very prescient ideas contained in these lectures. But one particular passage stood out to me, where he basically says that mental action is a function of connections. And we have the right to infer that when the continuity of these connections is destroyed, interrupted, or structurally impaired, that modification of function must ensue. So it's this early idea about the importance of these brain connections and how disruptions in these connections may give rise to different psychiatric disorders. And this is something that was recognized by NIH 150 years later in a program announcement that I believe funded some of the wonderful work that's been done by Leanne and her group called Connectomes Related to Human Disease, where they also talk about the idea of this disrupted, aberrant connectivity being implicated in the etiology of psychiatric disorders. And so that's sort of the approach of our lab, where our basic idea is to take the brain and we abstract it into a network and then use graph theory functions to characterize the brain as a network and see how those network disruptions might be related to psychiatric disorders. And we can take all kinds of different neuroimaging modalities. You heard earlier today about using functional MRI to characterize connections between different parts of the brain. We can also use diffusion tensor imaging to look at white matter structure, connecting different parts of the brain and create structural brain networks or structural connectomes. And when you do that, you can use graph theory metrics to characterize particular characteristics of the network. Some of the common ones that you'll see in the literature are path length or network efficiency or nodal centrality. And path length is essentially the number of edges that connect any two given nodes in a network. The inverse of path length is network efficiency. So networks that have long path lengths have lower network efficiencies. The other characteristic that you'll see is nodal centrality, which characterizes nodes in the network. So nodes with a high degree of centrality have a lot of connections between them. So if you look at the air transportation network, I flew out of a hub in that network in Chicago, coming here to Stanford. And so we can look at how these metrics are different in patients with different types of disorders. And that's the work that our lab and others have done, showing things like lower network efficiency associated with anxiety disorders. This has also been shown in mood disorders. Not only do we see lower network efficiency associated with mood disorders, but it's also correlated with symptom severity, as well as cognitive dysfunction that you heard about from Dr. O'Hara, like processing speed. And our group and others have shown altered centrality, or the hub-like nature of limbic regions like the amygdala and the hippocampus, as well as default mode network regions. And so we had the chance to look at how these metrics might be altered in a study that I was a part of with Dr. Luan Fan at UIC several years ago, where the goal was to look at patients with internalizing disorders, that is, mood and anxiety disorders that would be amenable to treatment with either cognitive behavioral therapy, CBT, or an SSRI, selective serotonin reuptake inhibitor treatment. And our goal was to look at this sample and see whether we can look at network characteristics that differed between patients and controls, network characteristics that might be predictive of treatment response overall, as well as network characteristics that would be predictive of treatment response in a modality-specific way. And this was work led by my former MD Ph.D. student, Paul Thomas, shown here, who successfully completed his dissertation last spring and now is probably delivering babies in his OB rotation. And so he looked at this group of heterogeneous patients. You can see the distribution of disorders there, and you can appreciate that a lot of the patients that also had major depressive disorder also had generalized anxiety disorder, social anxiety disorder, PTSD, panic disorder, and so forth. And again, the goal is to see what's different between patients and controls and what might be associated with treatment response. And we focused in a hypothesis-driven way on the uncinate network, which is shown here, which are nodes in the prefrontal cortex that are linked to the amygdala and the hippocampus through a white matter bundle shown on the right in brown. And it's an important white matter-based network that's important for emotion regulation and emotion processing. And our group and others have shown how this particular white matter bundle has impairments in white matter integrity, increases in white matter hyperintensities associated with symptom severity, as well as functional changes in this particular network. So it was a good candidate to go for looking at what subnetworks might be altered in these patients. And so what Paul found was that specifically for the left medial orbital frontal cortex, the local efficiency was lower in patients compared to controls. That is, the connectivity of that particular brain region to its other network neighbors was lower in patients compared to controls. Furthermore, it predicted at baseline CBT treatment response, and it increased with CBT treatment, and it correlated with symptom improvement as measured by the depression, anxiety, and stress scale shown on the x-axis. And this lined up really nicely with previous work published by Bodhi Dunlop and Helen Mayberg as part of the PREDICT trial, where they looked at functional connectivity between the subgenual cingulate cortex and the same left medial orbital frontal cortical region, and that they found that that connectivity selectively predicted treatment response to CBT, shown on the left, compared to medication treatment, shown on the right. So that was a hypothesis-driven approach. We've also taken a data-driven approach in the same data set where we use network diffusion modeling to look at how does information spread in the brain network. And we found this large prefrontally based network where information transfer was slower in patients compared to controls. And there was a key hub in this network in the dorsal medial prefrontal cortex. and connections to that hub region were predictive of treatment response overall, as well as selectively predictive to CBT and SSRI treatment, depending on which edge in that network you looked at. So one of the things that Josh Gordon talked about earlier this morning was sort of combining data-driven and hypothesis-driven approaches, and that's something that's been elegantly done here by Leanne's group, where they took hypothesis-driven selection of circuits or subnetworks, and also a data-driven approach to see how these subnetworks may be used to tease out the heterogeneity of mood and anxiety disorders. And they were able to show in this nice paper by Andrea Goldstein-Piekarski that these circuits can be quantified and predictive of treatment response to all different types of modalities, whether it was behavioral treatments or medications. And this work inspired work that we did at UIC in collaboration with Leanne's group in the ENGAGE-2 study that was spearheaded by Leanne and Dr. June Ma. And this was a study where we used those circuits as mechanistic targets of an intervention designed to treat two major public health problems in this country, depression and obesity. And it was a combination of an integrated behavioral therapy that looked at problem-solving treatment to address the depression piece and a lifestyle intervention to address the obesity piece. And this integrated intervention was called iCare. And the mechanistic targets that we were interested in looking at for iCare involved the cognitive control circuit, the negative affect circuit, which is elicited by looking at emotional faces that generate negative affect, as well as the default mode network, which has long been implicated in the pathophysiology of mood and anxiety disorders. And what we found was that in the cognitive control circuit, there was an interesting finding in that the usual care group showed that over a 2-month period, there was a decrease in the cognitive control circuit that was associated with an increase in anxiety measured by the GAD-7 6 months later. So basically, these neural changes in the usual group preceded the clinical changes, and we did not see that in our intervention group. So there was a significant interaction between our two groups. And we were inspired by this for our current study called SPEAK, which is using that same problem-solving treatment, but we're using an Alexa-based therapy chatbot to deliver it for patients with mild to moderate anxiety and depression. And so this is our solution called Lumen. It basically delivers 8 sessions of problem-solving therapy over 12 weeks. So you get 4 weekly sessions followed by 4 biweekly sessions. It interacts with the participant's smartphone to record ecological momentary assessment, as well as scheduling the sessions. And it's all connected on the back end to AWS architecture, as well as RedCap for data capture. And we engaged in an iterative design process in order to create Lumen, where we tapped people who had experience with real-life, in-person problem-solving therapy, in addition to those that were naive to problem-solving therapy. And they engaged in a series of structured surveys as well as semi-structured interviews. And the surveys asked about things like their user experience, asking about whether they liked using Lumen or was it easy to use Lumen. We also used the NASA Task Load Index to see what is the burden or the demands on using the app, as well as the Working Alliance Inventory to see whether there was a sense of trust that the participant had with Lumen and an alliance and an alignment of treatment goals. And then the semi-structured interviews covered a lot of those same concepts, in addition to asking about the benefits, challenges, and barriers. And so here's some of the characteristics. And what I want you to appreciate is that this sample was predominantly female and very diverse. And they actually found that they had a positive evaluation of Lumen. They found it relatively easy to use and fun to use. They did, though, note some medium levels of demand, especially when it came to cognitive effort. And then they also had good working alliance with Lumen. From the semi-structured interview results, there are several themes that came out. One was comparing using Lumen to in-person problem-solving therapy. Another one had to do with the task load. Sometimes participants felt rushed as they were going through their sessions. We also got specific suggestions on how we can make Lumen better, in addition to dealing with some of the technical issues that we had in this first iteration of the product. And so some of the lessons that we learned was basically dealing with things like the temporal lobe by making it easier for users to navigate their experience with Lumen, splitting up conversations, adding pause, repeat functions. We also created a workbook that people could track how their progress was going from session to session. And then we also provided feedback on their scales. This was the concert diagram for our pilot study where after recruitment and orientation, the participants did some basic surveys that asked about their level of worry, positive and negative affect, as well as dysfunctional attitudes. They also did an fMRI scan at baseline that tapped in some of the same circuits that we talked about before, the cognitive control circuit, as well as a negative affect circuit. And then after either being assigned to the treatment arm or the control arm, we repeated both the surveys as well as the neuroimaging. Here are the characteristics of our participants from that pilot study, and you can see again it was predominantly female, but also a very diverse sample. And again, our key finding was in the cognitive control circuit, where on the left, what you're looking at in the orange line is basically an increase in that cognitive control circuit score that was associated with better coping skills. And then on the right, you're seeing an increase in that cognitive control circuit associated with less maladaptive coping skills, avoidance styles. And so that was our mechanistic target of interest, and based on that, we're now moving on to the R33 phase. We also looked at some clinical results as well using the Hospital Anxiety and Depression Scale, and we see pretty good effect sizes on reducing depression, anxiety, as well as the total score. And then there was a very interesting finding when we looked at specific moderators of treatment response. We found that the most robust factors involved in a good clinical response to Lumen was being female, non-white, and having a college level of education or less. Which was really interesting to us, but it shouldn't have been surprising when we think about who was involved in the design of Lumen in the first place. We had a predominantly female, very diverse sample that helped us craft Lumen in the first place. So it's not surprising that those are the characteristics associated with the most robust response to the intervention. And that's just reminding you of those characteristics here. So to summarize this section, we see that brain network or connectome properties can help us identify targets for existing treatments like CBT. It can inform new treatments like eye care and Lumen. And that precision in intervention development not only informs where these interventions might be working, but also for whom when thinking about designing these interventions. And so digital mental health tools, as we heard from Dr. Bao's excellent talk, can also help us enhance precision in tracking disease as well. And that's what I'm going to talk about now. But I want to first highlight that this is also not a new idea. This is from the American Journal of Insanity. And what they talk about in this particular article was the importance of the ability to basically observe our patients in a tireless fashion in order to enhance the precision of our diagnoses and our evaluation, right? There's also another article from The Lancet back in 1859 that talks about the problems of studying patients outside of their natural environments, and that when we study them in the artificial environment of the hospital or the clinic, oftentimes we're losing a lot of precision and, quote, authority in how we manage our patients. Now, as you heard from Dr. Bao, we have these amazing technologies, and we also have all these tools that we can use for these tireless observations to capture how our patients are doing in more naturalistic environments. And that's the work that we have been doing as well in our lab, looking at how we can use these devices to develop digital biomarkers for our psychiatric disorders of interest. And so this is work spearheaded by my colleague, Dr. Alex Liao, where she developed an app called BiAffect, which replaces the default keyboard of your smartphone with a customized keyboard that allows us to track how you type. Importantly, we don't track what people are typing to avoid getting into privacy and confidentiality issues, but we look at how fast you're typing, whether you make mistakes when you type, even the rhythm of your typing can give us some information to help us infer the user's mood state and their cognition. And so we were fortunate to partner with doctors Melvin McInnes and Kelly Ryan at the University of Michigan, where they have the Prechter longitudinal study of bipolar disorder. And we had a sample of their participants use an Android version of the app for several weeks. During that time, they did daily ecological momentary assessments of their mood, their energy level, impulsivity, rapid thinking. There were also clinician-rated scales for depression and mania done on a weekly basis. And so in one of our first studies published from this collaboration from Dr. John Zulueta, he put a lot of these different bioaffect-derived typing metrics into a linear regression model and found that they were significantly associated with measures of mania from the Young Mania Rating Scale, as well as depression. And then if you look at what are the features or the typing metrics that are unique to depression versus mania, what he found was that backspace was uniquely associated with more manic symptoms, and then autocorrect or more typos was uniquely associated with more depression. So this is a cross-sectional analysis, but we also were interested in seeing, can we prospectively predict changes in these symptoms using this passively collected data from bioaffect? And this was work led by Jonathan Stange, who's now a professor at USC. And he was interested in looking at instability of typing speed as well as instability of mood ratings to see if those could be used as predictors of elevations in mood symptoms, controlling for baseline symptoms. And he found that they could indeed be used for that purpose, that instability of daily mood ratings and instability of typing speed predicted elevations in depressive symptoms in this cohort. And so what I've shown you briefly is that we can use these passive, unobtrusive measures derived from smartphone typing data to be significantly associated with measures of mood from clinician-rated scales. And we were fortunate in that this cohort also engaged in a neuropsychological battery that include the trail-making test, Part A and Part B, and the Tower of London task. And you heard from Dr. O'Hara how important it is to be able to track cognition in patients with mood disorders. And so we wanted to see if we could use these typing metrics to basically correlate with cognitive measures. And this is just a reminder of the trail-making test. It's basically a connect the dots task where you connect dots alternating letters and numbers. And this was work published by one of our grad students, Mindy Ross, where she looked at the association of trail-making with typing. And all of the subjects did the trail-making test twice during the day. So she basically bifurcated key presses that were done earlier in the day and associated those with the morning trail-making test and those that were done in the latter half of the day with the evening trail-making test. And what she found was that if you look in between subjects, so inter-individual comparisons, those that type slower also perform more slowly on the trail-making test. Likewise, actually, if you look intra-individual, if you type slower on a particular day, then your trail-making test was slower on that day. So we basically not only saw these between subject effects, but also within subject effects, which is really crucial in thinking about how this might be used clinically. Another thing we can do with the typing data is that we can express it as a time series. What you're looking at on the x-axis are key press orders. On the y-axis, it's the inter-key delay, or our measure of typing speed, how much time elapses between each key press. And once you've characterized the data like a time series, we can look at the regularity or irregularity of this time series and garner information from that. So this is just showing it sort of graphically that if we look at the time in between each key press, if it's pretty regular, that's a low entropy time series. It's highly regular. If the timing in between each key press is more irregular, that's a higher entropy time series. And this is work done by Alex Demos and John Bark. And we also wanted to look at irregularity of movements on the Tower of London task. So the Tower of London task is a bunch of balls on pegs. You have to get from a goal start state to a goal state in as few moves as possible. And so we calculated how much time it took to make each move and to look at the regularity or irregularity of those move times. And our hypothesis was that if it's associated with impulsivity or executive dysfunction, it should be pretty high entropy because people might make mistakes when they are doing the task and they might backtrack so they can take longer times in between each move. If they had thought about it in advance and they had planned it, they're gonna have more regular move times in between each move. And what we found was that, yes, indeed, the participants with bipolar disorder had higher levels of entropy of move times on the Tower of London task. And then using multi-scale entropy, they also had higher levels of entropy in their typing data. Furthermore, those two things were actually correlated. So typing entropy was correlated with Tower of London entropy. It was also strongly associated with variability in depressive symptoms, as well as variability in impulsive actions and feelings. And so not only do we see that the typing data can be used to be associated with mood disorders, but it's also associated with cognitive dysfunction that we see in these patients with bipolar disorder. And what we're doing now is a couple of replication studies. So here's one. It's an open science study in a large sample where anybody could download the app and participate in the study. And in a paper published by one of our students, Claudia Vessel, she looked at things like circadian changes in typing speed over time, used that as a covariate, and replicated some of our findings showing that higher levels of depression measured by the PHQ was associated with more typing mistakes, higher typing variability, as well as shorter session duration. And now we're doing similar work where we're trying to link the neuroimaging component of our lab with the digital biomarkers. And just, I see that the hook is coming soon, so I'll go pretty quickly through this. So one of the things that we're trying to test is whether typing speed is associated with connectomic correlates of cognitive dysfunction like processing speed. And I'll just end by saying some preliminary analysis from our unmasked study suggests that lower typing speed might be associated with lower structural brain network efficiency. So the hope is that we can use all these technologies to better track and treat these disorders and hopefully intervene sometimes before symptoms become clinically apparent. And I just want to end by thanking my collaborators like June Ma, who got me connected to Leanne and the SPEAK team, as well as the Connect Lab folks and Alex Liao, who leads the BioAffect project. Thank you.
Thank you. Thank you, Olu, for such a fantastic presentation. And it really is impressive how you link together so many important measures and you truly embody how do you now take this into clinically meaningful outcomes. We're going to make time for a few questions. Our other speakers have agreed to start just slightly later, so let's see if we have any questions from the floor. Just come to the microphone, and I'm looking at Rachel to see if we have one on Zoom. Okay.
This is actually a personal question of mine. So with the bioaffect, the first data set you were talking about with bioaffect, where you're doing the Young Mania rating scale, out of curiosity, was that sample, were they treated?
Yeah, so this was a treated sample, but a lot of them, they were kind of selected because they had rapid cycling bipolar disorder, so they were pretty, the symptoms varied quite a bit during the duration of the study.
And did that correlations, I think it was 0.75, stay pretty stable when you were considering different genders, type 1 versus type 2?
Yeah, unfortunately the sample size was too small to parse it like that. We're hoping with our larger study now we can start looking at that. Although the majority of them in our current study have major depression, we just have about 25% of the sample with bipolar disorder.
Wonderful, thank you.
Thank you so much. Wonderful presentation.